This is another version of the previous slide in list form. It may be clearer for some of you while the other one is better for others. Anyway, it doesn't hurt to repeat this. I'll leave it running for a moment. The first question is, does causation come from the external or internal environment? Not always an easy question to answer, as it might appear superficially, as external forces that would ordinarily be undamaged into healthy tissues may well damage degenerate. So the issue is often a mixture of both external and internal forces and effects combining to cause the degeneration. It is almost always an external force, though, that triggers the symptoms. And again, this force would not be considered particularly significant, but the trigger comes at the end of a line of ongoing degeneration and continuing subclinical insults. The trick is to determine whether the tendinopathy is inflamed or not. If it is inflamed, then generally the cause is obvious and the etiology is known. If it is not inflamed, then the easy thing to do is blame the trigger. But it is unlikely that your treatment will work or be shorter than it would be otherwise. So let's look at the internal influences and forces that may cause degeneration on the next slide, where the major issues causing or contributing to tendinosis are discussed. We really haven't discussed axoplasmic flow, or axoplasmic transportation if you prefer. It is a transport of protein through the core of the nerve. It occurs in both directions, towards and away from the spine, and has varying speeds, termed fast and slow flow. For this discussion, we are only interested in two types of protein, both of which flow away from the spine. Fast flow that replenishes the neurotransmitter substances at the synapse, and slow flow, which replaces trophic nutrients at the tissues being supplied by the nerve. Compromise of AXT occurs more easily than does electrical neuropathy, possibly because a small block can lead to a build-up of the flow and clogging, but I wouldn't like to take that argument too far. In addition, AXT compromise can occur when there are two or more blocks, neither or none of which by themselves will be sufficient to cause clinical AXT flow loss. This is the double or multiple crush syndrome. The degree of block here can be to a level that it is a neuropathy, but if one blockage clears, then the neuropathic signs clear. This can be episodic if the block point is episodic. In all cases, the effects are seen distal to the distal block point. It is reasonable to say then that AXT compromise can and does occur without the conglomeration of signs and symptoms of radiculoneuropathy, but will always occur with them. If you believe that an AXT loss has caused more than just weakness and possibly paresthesia, if it's bad enough, but also sensory loss, reflex changes or neuropathic pain, you would do much better considering this a neuropathy or a radiculopathy and dealing with it accordingly. As AXT is relatively easy to compromise by compression, torsion, kinking and traction, or any combination of these, treating it is also relatively easy. Get rid of the block or blocks. The block can be in the spine by a stenosis that is too minor to cause symptoms, but large enough by itself to limit AXT flow to the synapses, causing a fatigable weakness in segmental distribution. This can combine with, say, a compression of the wrist, giving rise to carpal tunnel syndrome, in which case you would see the paresthesia or the signs, fatigable weakness signs of medial neuropathy. AXT as a hidden etiology has to be by definition asymptomatic, and the only evidence it will be fatigable weakness, as this is a consequence of synaptic failure distal to the most distal block point. So effectively you have a radiculoneuropathy that is asymptomatic, and has no signs other than fatigue or weakness with a distribution that varies depending on where the block is. It might be possible to provoke paresthesia with some clinical tests such as Tinel's, abduction of the elbow, Phelan's compression, straightforward compression of the wrist, and of course neural tension tests whose positive would have to be paresthesia. Finally, you can treat the block, manipulate it its fastest, and retest for strength. The degenerative effects of AXT are due to trophic malnutrition following blocking of slow flow. You cannot directly test for this in the clinic. The thing is way too slow and there's no obvious symptoms from it. But you can infer it's present by establishing that fast flow loss is present. This does not mean that AXT is the cause of the presenting problem though. But you will still treat this as you treat the fast flow issue. Mechanical causes are less of an issue in the upper quadrant than they are in the lower, simply because the amount of force generated by walking, running and doing other idiotic things is much greater than they are in the upper limb. Don't get me wrong, mechanical causes of shoulder problems and wrist problems and so on are an issue, but not as much as they are in the lower quadrant. We can, because of that, concentrate for this webinar on the neurological and neurophysiological. We can cut down the hunt even further by acknowledging that neurologically caused weakness is likely to be part of a condition that the patient already knows about and may even have had diagnosed. Most radiculopathies have been identified, and diabetic neuropathy generally has neuropathic pain and/or paresthesia. In addition, any condition that causes weakness is likely to produce sufficiently intense symptoms as to prevent the patient carrying out activities that would trigger the pain. So, for the most part, we are left with neurophysiological issues, these being reflex inhibition and segmental facilitation. The exception to this is axoplasmic flow compromise, which can be from a single mechanical blockage or minor blockages, as in double crush syndrome, and may be asymptomatic and not overly interfere with function. Both have a number of characteristics, but for the purposes of the initial investigation to determine if either or both are present, weakness is the main indicator. So strength testing becomes your first test. The slide speaks for itself, so I'll leave it speaking for a moment or two. To search for weakness of neurophysiological origin, we have to consider how the two conditions are characteristically weak. Segmental facilitation is non-braking and non-fatigable, while reflex inhibition is braking and non-fatigable, and often only demonstrated with eccentric contractions at the end of a range of motion. We are also not interested in every muscle group, just those around the joint for reflex inhibition, and through the C5, 6, C6, 7 segments for segmental facilitation. If we find weakness anywhere else, it is probably not relevant to the identification of neurophysiological weakness, but is nonetheless interesting and it should be pursued later. However, if we find a weakness different from non-fatigable, then we are probably correct about assumptions concerning the likelihood of neurological involvement, and this now needs to be investigated. This is particularly true of axoplasmic flow compromise, which certainly can exist asymptomatically. This slide is self-explanatory, but segmental facilitation weaknesses is distributed through the segments innervating the muscles, and with tennis elbow that means primarily C5-6, but may also include, but to a lesser extent, C4-5 and C6-7. It is worth noting that the effects of segmental facilitation are more profound the more proximal you look. Reflex inhibition is found around the joint that is causing it, over which the muscle runs. So in the case of tennis elbow, the weakness and other characteristics will be found at the elbow and the wrist, and so will the dysfunction that is causing it. Whereas with segmental facilitation, you can't be sure where the dysfunction is, just that it's somewhere within the segment. There are other effects of these neurophysiological conditions than weakness, and this diagram includes them and summarizes the differences between the 4 likely candidates for etiology. It's worth repeating again that the effects of segmental facilitation are more obvious the closer you look to the spine, and the same can be said for the effect of the mechanical input or the wobble. Remember that when wobbling for effect on segmental facilitation as a diagnostic, do not wobble over the presenting areas, as this will diminish reflex inhibition effects and confuse the diagnosis. I'll leave this slide running for a few moments. There are a number of factors that can confuse the picture. First, is the etiology that you found really the etiology, or is it an effect, or has it got nothing to do with the problem? In the case of tendinosis, reflex inhibition is very unlikely to be an effect, although that statement is untrue when discussing articular problems. It's difficult to see how this can reasonably come about. If it's unrelated, then there is probably no way of knowing this, so an assumption must be made that it is causal and that it needs to be treated. Whether or not you do treat it must follow a risk-benefit assessment and a long discussion with the patient, and we will do this soon. Often you will find a combination of segmental facilitation and reflex inhibition, and it can be difficult to sort your way through the problem. Typically, in my experience, the reflex inhibition will dominate locally, while signs of segmental facilitation will be seen throughout the rest of the segment. The scratch test helps with this, as it's quick and obvious and identifies the segment level nicely. Facilitation is a little more difficult. you have a painful tissue, and it is reasonable to expect this to cause segmental facilitation. So finding C5-6 facilitated in the case of tennis elbow is no real shocker, nor is it an absolute indication that segmental facilitation is a cause. But if there is a pre-existing nociceptive problem in the C5-6 segment, that will be lost in the facilitation caused by the tennis elbow. So how will you find out that this facilitation pre-existed the elbow problem, as this is asymptomatic, but nociceptive dysfunction will need to be treated. Axoplasmic flow compromise can be difficult to interpret, but not differentiate from overt neuropathy. The distribution varies on where the crush is, and if it's a case of multiple crush, it will be distal to the distal crush. Finally, all of these can be combined, and the examination and analysis will be very difficult indeed. The assumption that reflex inhibition and segmental facilitation should be treated is on the face of it reasonable. However, there are risks involved, and often the assumption is ignored and no treatment given. But for the purposes of identification of etiology, if a second or more source of segmental facilitation other than that coming from the painful tendon is found, it is reasonable to assume that it is an etiology. For this, I think you have to accept that segmental facilitation is caused by nociceptive input rather than simply any aberrant input. This was discussed in a previous webinar. If you do accept this, then you can look for sources of facilitation other than the painful one by stressing the tissues innervated by that level to provoke pain. Quadrant testing, shearing, palpation, etc. may all convert nociception into pain. You can also make the same assumption that is causal about reflex inhibition locally to the presenting problem. Generally, combined facilitation and inhibition do not present too much difficulty in separating out by wobbling at first away from the putative causal joint, but in the appropriate segment. If the local weakness remains, but segmental weakness diminishes, then the local weakness is reflex inhibition. Multi-crush syndromes can be difficult. The signs are felt distal to the last crush point, but summation occurs with each. Look to your anatomy and utilize local tests such as Tinel's, Phelan's, position of joints, which would stress the nerve, upper limb tension tests, and that type of thing. If all of the effects are combined, then a confusing picture will emerge that will test your intellect considerably. Good luck with that. The decision as to whether or not you and the patient should embark upon this course of treatment involving etiologies and contributors is completely contextual and most certainly not automatic. The biggest problem with this approach is that you'll be treating asymptomatic joints, and the best you can hope for is that they remain that way, asymptomatic. There is nothing worse than a patient coming in for tennis elbow and leaving with tennis elbow and neck pain. Try it sometime, it's not pleasant. Neither the patient nor the physician will forgive you, especially if you've undertaken the treatment without a full discussion on the risks and expenses of the treatment with the patient and gained their full approval. This might seem obvious, but I've seen too many teachers failing to emphasize this and too many PTs doing it as if it was a right. There is a real risk with this approach, and it needs to be assessed properly. Is the patient in so much trouble with frequent recurrences that it is worth even offering the risk, or can he and she come back every 6 months or so for a couple of sessions? For a long-term improvement, not only does the presenting condition need full treatment, including stabilization therapy, movement rehab, education on leisure and work activities, and modification of these, but so do the etiologies, and there may be quite a few to deal with. This gets expensive in both time and money for you both, and of course it might not work, and you won't know that it's whether or not it is working over the long term for a year or more. So is the time and effort both of you must put in worth it? Or again, is returning every few months a better option? Only the patient really knows if it's worth the risk and the effort, but they need information. This is an overview of treatment. The most interesting part of the diagram is on the right hand side. First, make sure the complaint is treated properly. I know this sounds stupid to have to say this, but I've heard very experienced therapists say that if you deal with the etiology, then the problem will disappear without the need to treat it. Even in a theoretical world, there's no reason this should be true. The pathology is present. It might not get any worse if you deal with the etiology, but there's no reason to suppose it will get better. Whether you treat etiologies should be dependent on how frequently recurrences occur and how difficult the primary problem is to treat. If you have a very rapid and profound effect with local treatment, I would suggest you don't treat the etiologies but discharge the patient. If treatment is not working by the second or third session or improves but relapses, then I would treat local etiology. For example, if I found that the patient had segmental facilitation, say from the C5-6 segmental dysfunction and an abducted ulna, then the ulna would be treated and the spine left alone. Only if this failed to bring about complete recovery in tandem with local treatment would then I move to the neck, or if the patient returned after being discharged, would I then move to more distal areas and even treat secondary etiologies. This is a summary of the assessment and treatment of the primary and secondary diagnoses. That is, the patient's presenting complaints, etiologies and contributors. First, make the diagnosis. Either pattern recognition, hypothetic deduction or abduction, or script focus hypothetic abduction. Check the diagnosis. Look for errors in bias and cognition. You can do this by using differential diagnosis, completing the exam for premature closure, and consideration of how likely the condition is to be present. Then, in the abstract, consider the forces and influences, neurological and neurophysiological, that may cause the problem. These include internal and external stresses, neurophysiological, neurological, and so on. Reflex inhibition, segmental facilitation. Then search for the etiology based on what you think the causes are likely to be, and then ignore everything else, otherwise you're going to be treating stuff that is irrelevant. For treatment, treat only the primary diagnosis in the initial instance unless you've got a special case, something that's been referred to you with plenty of recurrences, and something that's just not getting better. But treat the initial diagnosis otherwise initially, send them away with the exercise program, whatever it is you're going to do with them, and then when they come back again, if it's rapid return, then consider treating local etiologies, or giving them the option of coming back and just having the standard manipulative treatment plus rehab exercises. If you go the etiological route, you treat it locally rather than going into the spine if you've got a peripheral joint problem and so on, but treat locally, and then if they come back again it needs more, then treat more distal etiologies, and it'll cut down the risk of you creating pain in otherwise asymptomatic joints. and then assess on the mid and long term. The assessments will be sort of self-referred anyway for the most part, in that the patient will come back if they have to, hopefully, but you may also want to look them up in a year or so and see how they're doing it, but for your own learning benefits really. Anyway, hope this helps, and good luck with it. It's worth doing just as a practice on patients, even if you have no intention of treating the etiology. It's a good thought exercise, and it'll keep your brains in shape. Okay, so we're done. Hope you enjoyed the presentation on etiologies. Remember that they are extensible from the specific case of tennis elbow to pretty much everything else. But we do need to obviously talk about mechanical forces in the lower limb, and we will do that sometime soon. I hope that you actually look for some of these etiologies. It's one of the most rewarding things you can do in the clinic. Even if you don't plan on using it until you're more confident and you feel the patient needs it, the actual exercise of finding them is very worthwhile. To make the diagnosis, then consider the forces and effects that are causing them, and then go look for these specifically, and when you find them, it's incredibly satisfying, and it's a very rewarding experience. I'd recommend it to anybody. Labelling things overuse is exactly the opposite. It's laziness, and you're probably wrong if you do that. The chances are that it isn't simple overuse, and that there is something else going on that's previously degenerated the tendon. I also hope that the quiz was useful to you. If it does nothing else but disabuse you of the idea that neurological signs are going to be very easy to spot when you're sitting in front of the patient. Those eyes weren't that simple, and even if you do make one out to be a little bit different, you can't say that it's extreme enough for you to get worried about it. When you actually move the eyes by tracking and you see it's paralyzed, it just jumps at you. And it's a wonder to me that something that could be completely paralyzed maintains a central position as much as these ones do. Now, there are obviously more obvious ones, but these two give you a clue that it's not always that easy. Anyway, I hope to talk to you again soon, and just be safe out there. It's getting worse rather than better for the moment, so be careful. Take care. Bye. Sometimes this is difficult to see until they track with their eyes. One of the problems we have is that we don't look at faces very often, and so pattern recognition is not triggered, even though we're obviously familiar with faces. We are apparently not very familiar with abnormal faces. In fact, our perception system goes a long way to making them fit into our pattern. Experienced clinicians, neurologists, ophthalmologists and so on are used to looking at abnormal eyes, so they will pick this up. The point I'm trying to make is that this is not as easy as it looks, so don't beat yourself up too bad if you do miss it, providing it's as subtle as this.